glad to have you be able to see the length of my new board. I can't wait to talk to you about this. So a bunch of you have gotten confused and have had asked questions about certain discharge settings where patients actually go for therapy versus not, where they end up, all that stuff. So we're going to talk about it all right here to answer some of the basic questions. I can't look at your comments though, kind of a bummer. But what I'll do is after I'm done with all this, I will look at your comments and I'll answer them. All right? So let's chat. We're going to talk about the difference between inpatient and outpatient. We're going to talk about how the patient's journey of becoming their own OT alongside all this, and how to best serve your patient by being the liaison to where they should be going. So I'm going to be talking from an acute care therapist perspective, just to give you guys the bare bones of understanding what exactly each of these mean. And also it may enhance your experience in any of these settings that you work to decide, well, actually, maybe the patient actually needs this setting instead of where I'm working with them. So it will help you be the best liaison for their patient journey in terms of their rehab recovery or their functional recovery. So let's first talk about acute care. So acute care, either patients are coming planned or unplanned to the hospital. And this is where patients either have a planned surgery like a knee or a hip replacement, spine surgery, all that kind of stuff, or unplanned. It's a medical emergency. Maybe they came in for a viral infection or the flu. Maybe they came in for a polyortho trauma where they're affected and impacted by trauma, cognitively, physically, bones broken, all that kind of stuff. Maybe it was some sort of cardiac experience, cardiac arrest, or they needed an emergent situation where they needed a surgery. So they're coming to the hospital for a short length of stay. Basically, when that patient gets a scan done or all that kind of stuff, we're just talking about unplanned experiences, emergent. Let's talk about trauma patients, for example. They get all their scans done, the doctor finds everything is clear, they're medically stable, and then they need to move forward to the next place. So what does that mean? Functional instability does not equal medical stability. So a patient, in order for them to stay in this acute setting, they have to have a medical need. And where do we come in on that? We want to be optimizing the patient's experience to really advocate for them and to them in order to help them, guide them through the process of what it means to be their own OT alongside their journey. Now I put up here, let's talk about it being at the high school level. Let's talk about acute care, their short stay in a hospital setting being their high school level. They're getting the basic information. They're given the structure, the formula of how to get through all this if necessary, or which direction to go next. And they're relying on the people who are engaging with them at the hospital to tell them where to go next. This is the first time they've ever done this before. So occupational therapy provides a huge component to this, of teaching the patient how to navigate their own healthcare system and their functional stability through the process when there's an unplanned situation. Now, are they home ready? We decide if they're home ready. Can they go home in this state? Do they have all the tools they need? Can they go home without home health OT? Can they go home with just outpatient OT? So that's up to us in terms of our OT scope of seeing this patient. Let's say yes. Okay, so yes. Do they need outpatient like a clinic? Do they need outpatient community-based for their primary care needs? We'll talk about that a little later, what that looks like. Or do they need more of a like adult day program where they can go to during the day? Or do they just need home health? And I didn't put home health up here because I think we're pretty aware of what home health is. But if the answer is no, they cannot go home, where can they go next? Okay, do they still have medical and functional needs? Long-term acute care would be our answer. So long-term acute care is an extended version of acute care, but they're staying there more long-term in their acute medical condition. So patients with a ventilator, patients with a low-level brain injury, maybe like a low Rancho Los Amigos scale of like 1 to 3, 1 to 4, 1 to 6, whatever it is, and maybe they need a vent, maybe they just are medically compromised where they can only tolerate so much minute moments of therapy, but they need kind of that medical care and they need a physician to check in on them every single day. But they still benefit from therapies or even just the therapist coming in and monitoring their performance and their ability to actually participate in determining their appropriateness for therapy or their functional participation. Okay, so if they still have a medical need, long-term acute care might be a good idea for them before going to our more traditional rehab settings. Now, let's say they don't have a medical need. Let's also say that the patient didn't stay in the ICU for 3 days while they were in acute care, because that's one of the qualifications for long-term acute care is the patient had to have had a 3-day ICU stay in the acute care in order to be able to go here at some point. So now we talk about functional needs. What functional rehab needs does the patient need? What level of assist are they at? Could they go home with just home therapies at the level of assist that they're at, or could they go to a rehab setting where they can get more intensive therapies, or somewhere in between that? What about the value? This is so important. What about the value of the therapy the patient will be getting? The value of what the patient will be getting will differ between acute rehab and skilled nursing, as well as outpatient settings and home therapy settings and transitional living unit settings and adult day program settings. Whoa, we have so many things going on. How do we decide where this patient goes? So let me break it down a little bit for you. With acute rehab and skilled nursing, just those main brackets of time where patients can stay. So for example, acute rehab, a patient has to tolerate 3 hours of therapy a day, which means that the patient will have anywhere between that 1 to 3 hours consecutively during the day with their therapist. Whether it's 2 types of therapists like speech and OT, or it's PT, OT, and speech. So either way, the bracket of time that they spend during the day is 3 hours a day, and then the bracket itself of how long they stay in acute rehab will depend on their functional needs and the documentation that you put down in terms of what they need that's skilled and billable, and what barriers are still arising within their day-to-day IADLs, community management, and all that jazz. Skilled nursing, however, is also going to be a bracket of length of stay depending on their functional needs, also documenting thoroughly in that aspect, but that may vary from 30 minutes a day to 2 hours a day, depending on how they're meeting criteria within their insurance, but also it's up to us in order to document that they truly have value there, and also when we need to start weaning them so we can be in alignment with insurance. So these, because there's functional needs, insurance companies have delegated a certain amount of time brackets for them. However, can we spend that time with most value and most intensity to get the most bang for their buck in that opportunity? That's going to be really important, and the patient's tolerance for that. And also, we go back to acute care to understand, help the patient and family understand why this is a benefit, especially since they're dealing with an acute situation that they don't quite understand yet. And we're there to help be their liaison, to really help them, guide them through that grieving process, no matter where they're at, whether they're stuck or they're moving through it, to get to this point for their loved one, and for the loved one to understand why this is so beneficial. Here's a bonus question for you. What tool is the #1 tool that I always speak about that you need in your toolbox if you have no other skill set as an occupational therapist? Occupational profile. That's all you need, right? If we can use the occupational profile at any aspect in these settings, we can really identify how we document the definition of what this patient truly needs for skills, their roles, how they spend their time from the moment they wake up in the morning to the end of the day. We really can hone in on the barriers that are impacted by their diagnosis that can really get them the justification of where they need to go. Same thing with long-term acute care, but again, remember, this side of the board right here is medical needs. This side of the board here is functional needs in order to access those places. Okay, let's hypothetically say you have a patient who has a neuro trauma or ortho trauma, or something's happening, or it's some sort of neurological deficit that's acute, or it's an exacerbation due to something that's happened with them. And they can't quite tolerate 3 hours a day. Well, I recommend putting a bridge program together by having them go to long-term acute care if they've had at least a minimum of 3 hours a day, 3 hours, I'm sorry, not 3 hours, getting confused here, 3 hours versus 3 days. If they've had 3 days, again, in an acute care setting in the hospital, they have an opportunity to go to long-term acute care before they go to acute rehab, but this is their bridge. Before they get here, if they can't quite tolerate 3 hours, we're going to try to backpedal a little bit and say maybe they need to start here first, so they can have the opportunity to come here, okay? It's better to do this instead of this, because truth is, are they really going to get the most bang for their buck here? And in long-term acute care, we have therapists that actually work there that understand and have the patients to make tiny small gains with their patients. And so they have to be more keen on their skill set here to really hone in on breaking down activity analysis to its minute. And so that will really help justify when they're actually ready for acute rehab based on the tolerance level, because here they probably are not tolerating as much. And that's going to be a really important piece to that. Okay, so we're going to keep going here. So we have decided that, okay, patient's going to go X, Y, Z, but let's say they're done with all kind of like the institution type of things that's happening, or they're staying somewhere that's not their home. But let's go back to outpatient, okay? They're in their home, but they're not homebound. They can go to a clinic, community-based for primary care, or mobile outpatient. Now these two are fancy ones. These two are a little bit more, oh gosh, what's the word? They're not really up and coming. They've been around for a while, but it takes some time for everyone to get a wind of what's been happening. So I'll catch you up to these two. Traditionally, we're really familiar with more of the clinic-based. Like you go to a hand therapy clinic or an orthopedic-based clinic, or you go to neuro or vision, that kind of clinic. And they go there for an hour and then they come back home. Maybe they'll go there 2, 3, 5 times a week, depending on the therapist's decision and all that stuff. Again, functional needs, right? So difference between the functional needs in this clinic versus the functional needs in acute rehab or skilled nursing facility would be that here you're focusing more on getting them to the instrumental IDLs, community integration, and just overall ability to enhance their more dynamic, or I would say more complex skills, not just the basic bare bones. And if you really actually want to elevate beyond that, and you know that they still could be working on things a little bit more detailed, but they're not quite ready for home yet to go to outpatient, you can even do a transitional living unit. The transitional living units, these are unique because they tolerate 4 to 6 hours a day of therapy. They're there the whole time. Consider it like a dorm or group home. It's not really a group home, but it's temporary. So I'd like to think of these more like, if you Google Center for Neuro Skills, that's an exact replica of what a transitional living unit looks like. So that can be also an adjunct to this if it's appropriate. And not all patients will fit there, but it's something to consider. Okay, so back to clinic. So we're going to go back to community-based actually. So functional needs and maybe maintaining or achieving lifestyle management goals. Let's talk about how you go to the physician's office and you go there for maintenance. You go there every 6 months or a year to get your checkup. Imagine going to get your checkup with an occupational therapist, whether they share the office with physicians or they have their own clinic. It's community-based, it's focused on managing and redesigning lifestyle changes such as obesity, diabetes management, cessation of smoking, migraines, pain management, congestive heart failure, you name it. What kind of chronic conditions impact patients that go to the hospital all the time for readmissions that can be maintained? And so this is a huge component that USC actually focuses on in terms of their lifestyle management and redesign program, where they actually have a multidisciplinary team where people are able to come to their appointment, so to speak, and go back to back to back with each of their disciplines to talk about these things. And with OT here, this is an opportunity for us as a community here to broaden our horizons of how we can actually open these clinics or collaborate with physicians out in our community. And I highly encourage you to start looking into this because our healthcare system is changing, where patients really need more of this, but how do we really set them up for success in that once they've graduated from all this? So they've graduated from high school, community college, Bachelor of Science, MS, PhD, but how can we elevate their PhD level? I think about the patient's journey going along this way, like where they've really enhanced their skills to truly be occupational therapists for themselves based on the skills that we've given them, but how can we enhance their PhD skills? How can we help them implement it on a daily basis? How can we help them live their life to their fullest in their meaningful activity? So this one is a big one here. We don't have enough therapists contributing to getting grants and figuring out how they can provide these services within the communities, and we need more of that. I also highly recommend that if you're in school right now, come together to offer senior wellness services, fall prevention services to your community of older adults. And open up the door and dialogue with your community at where your college is to talk about how you can offer these services to the community while you're learning. Have that hands-on skills. It's going to be an effective skill set to have along this trajectory, because maybe patient doesn't have access to this, and you can bring it along the way with you, where you can actually teach your patients these skills throughout all this, and you gave them maybe a handout on something that might be more effective when they've recovered in their healing process. This is a huge component. Get that hands-on skills if you're a student. Primary, senior, or senior therapist, I highly recommend that you start thinking about doing this per diem or something. Try to incorporate and develop it. It's not impossible, I promise. Okay, so mobile, this is interesting as well. Some therapists have taken it into their own hands to create an outpatient service that goes mobile. Now, this is ideal for our patients' needs. They may not be able to go to a clinic, and does it make sense for them to go to a clinic? Not necessarily, because these patients are doing day-to-day things every day at the grocery store, at the bank, at the post office, on the park, when they're walking their dog and playing with their dog, and they're engaging in their social environment. There's so many things that our patients are doing in our community that this mobile outpatient service that a therapist can provide can come to them or take them around to these places, X, Y, and Z. This is also something that's been up and coming throughout the nation. We have, there's an individual that I met at an OT conference that does this in Santa Cruz area. I also am aware that there are some in Colorado that do this. So this is a fantastic way to really emulate what OT does within the flesh of the activities that our patients do. Definitely two things that I hope that we have more therapists engaging in. Now, on another adjunct component here is adult day programs. You might find that some families are not quite sure where their family member, their loved one can go during the day. Kind of like when you think about activity, like an activity day program, like where someone can go and spend their time all day. You know, they don't work, they want to find more leisure, they want to enhance their skills or maintain their skills. Through that process, they can go to an adult day program, like a brain injury related day program. It could be community based, could be an older adult or senior wellness program. So Google, guys, Google these things and see what's out there. Type in random stuff there and let me know what you find in your neighborhood and in your county and in your state to really help enhance the patient's experience in terms of their ability to access things along the way to really gain and maximize their functional independence.